Hey everybody, welcome to Taylor Tuesday again. I'm your moderator, Mike King, and with my buddy Ira here. We're thrilled you guys could join us, hopefully again, and if not, first time people, welcome. And thanks for joining us here on Taylor Tuesday. Do I sound enough like a sportscaster, Ira, yet? We'll see, I'm working on that. Anyway, that's my next career since this one's a dud, I don't know. Yeah. Anyway. We have a really cool content tonight with Doctors Connors and Trotter, and I think it's going to be super enlightening. I've been looking really forward to this as well. I played with these units, and Ira actually helped teach me about a couple of these things. I just don't know enough about them and didn't know enough, so I'm really excited about the content. So, Ira, if you move the slide up for me, please. I want to remind all of you, or tell you for the first time, that please take advantage of going to our portal and taylormedical.com. And if you want to actually replay this or go back through the materials again, look at all the slides, listen to what's going on, you can go up there, just click on the webinars up in the top right side, and you'll be able to go through all of our webinars, actually. And I don't know, Ira, we're up to about 12 now, right? Or something like that. We've had some amazing content, and every time they just keep getting better and better. Not that I'm raising the bar there for you, Kathleen, but we'll just put it up there for you. But they get better and better every time, which is just awesome. So if you can bump up, Ira. I want to remind everybody that most of you that are our regulars have gone through this, but if you have not, you need to. Take the time to have your staff or yourself develop the list of products that you use, you're currently ordering. If you're able, put them in an Excel spreadsheet. Some of us are good at that, some of us are not, but there's someone around that can help you do that. Get your kids to do it for you. But we need a list of your current vendors, descriptions of the things that you order, who you order from, the manufacturers, the SKUs if you have them, unit of measure. Do I get a 30 cc bottle of something? Do I get a 6 cc? Do I get a 1, whatever you're using, and what you're paying for those. And then mail that over to Carla and her team at admin@taylormedical.com, and you get a completely free cost analysis. As everybody here knows, this Taylor Medical is a completely free service. It's only upside. And how many things in medicine can we say that about today? There's only upside for anybody who participates in this. And we're the largest GPO that's servicing podiatry today, which is very exciting. But get your free cost analysis. And I know that we can guarantee that you will have some substantial savings. So, Ira, I'm going to turn it over to you to introduce our illustrious speakers. And I will step away, and I'm excited to listen tonight.
Thanks, Mike. It's funny. We joke around, and I joke around about podiatry being a small space. And those of you who know me know that a lot of times people have nicknames for me, and one of my favorite nicknames is Rolodex, because I seem to know everybody all around the country. And so I was really excited when Rob DeWaters, who is the owner of Medical Wave and one of our trusted vendor partners at Taylor Medical from the very beginning, volunteered John Connor and Kathleen Trotter. I don't know Kathleen very well. In fact, we just spent a little time getting to know each other a few minutes ago. But John and I actually did our residency together. And we've known each other, over the years. It's been quite some time, but I know that he's done some great things in the field of sports medicine and has really helped bring podiatry to the forefront in that area, which I think is very, very important. Everybody has different niches in medicine, and everybody does different things. And I think that what John's done in the sports world has been great for podiatry. So with my pleasure, I'm going to introduce both these speakers. Dr. Connors is a world-renowned sports podiatrist who's been practicing for 21 years and has been the medical provider to many elite athletes, both professional Olympic runners. Dr. Connors has lectured nationally and internationally on various sports medicine topics, and he's a competitive athlete and a marathon runner who's completed over 15 marathons. I'm tired just reading that, by the way. And then Kathleen Trotter, Dr. Trotter, and I were just talking, and I guess she goes by Katie. She is one of the most accomplished high school runners to ever come out of New Jersey. She attended Stanford University and was an 8-time All-American and a 2-time national champion while competing in cross country and track and field. After earning her undergraduate degree at Stanford, she went to Chicago, went to the William Scholl College, and then did her residency in Chicago as well with Dr. John Grady, who many know is a very well-known educator in our space, and then came back home and went to practice with Dr. Connor. So I'm going to actually disappear and turn it over to Katie and John. And on behalf of Taylor Medical and our community, I really want to thank you both for joining us and enlightening us on a technology that I think is probably underutilized and needs to be used more in our profession.
And don't be afraid, everybody, to throw your questions out into the chat box. So at the end, Ira and I can quiz our speakers about tonight's presentation. By the way, Katie, I noticed your middle initial is Q, so now we're going to call you the Queen of Sports Medicine.
I like that. Very good.
Thanks, Ira. Thanks for coming into this webinar tonight. We appreciate you coming. Hope everybody's doing well in this crazy time, in this crazy world, and I hope everybody's practices are starting to pick up during this pandemic. A number of years ago, when I first started my practices, we have a practice in New York City and in New Jersey. I had a vision, and that vision was to build up a sports medicine practice. And with hard work, dedication, it paid off. And we have a very nice practice, both in the sitting down here. About 5 years ago, I brought Katie on as an associate, and now a partner, and she's been a fine addition to our practice because she gets it. She's a standout athlete, 8-time All-American runner out of Stanford, very academic also. And we constantly are looking, because of our sports medicine practice, what can we do to help our patients? How can we get them better quicker? So we're constantly looking to see what's out there, what modalities, what type of surgical procedures are there that's new, and how can it help our patients get back to their particular sporting activity. Now, the school of thought is that you have to learn, and Katie and I both go by this rule, you have to think outside the box. What we learned what I learned and Ira learned in medical school 25 years ago, things have changed. Things that when we learned in medical school, the shock wave, the stem cells, the PRP, things like that, and different surgical procedures weren't there. So you always have to look forward and see what's new and change with the changing times. And having a sports medicine practice, we're constantly looking at these different new modalities that are out there. And a large part of our practice, and that's the topic of our conversation tonight, is talking about shockwave and EPAT, which is a major component in both our practices. And it's often the first line of treatment, our first line of treatment modalities when we're working with the patients. So we're going to talk about it 20, 30 minutes on mainly the clinical applications of shockwave, but Katie's going to spend a couple minutes talking about the biology and the science behind the EPAT and shockwave therapy. So go ahead, Katie.
Yeah, that sounds good. Thanks, Dr. Connors. And so I'm just going to, like Dr. Connors said, just give you a brief overview of the technology, the biological effects, the scientific documentation, just to refresh your memory. I'm sure we're all kind of aware of all this right now, but it's good to go over before we get into the clinical applications and kind of how we use shockwave in our office and our protocols. So we all know the shockwave technology has changed quite a bit over time. What once was a high energy machine, sorry, I'm having technical difficulties here. What once was a high energy machine requiring anesthesia is now a low energy machine. You can see that here on the right. And this has become our first line of treatment option for acute, subacute, chronic, all kinds of sports medicine issues. It's great because it's quite cost effective, and it has been very profitable for our practice, and it can be for you as well. And you will see that as we move along further. So as we know too, that it's been ever since 1991 that we have been using shockwave in sports medicine. And why is this? Well, this technology is that acoustic pressure waves promote a vascular response to allow healing, analgesia, and mobility restoration. It's non-invasive. There are no contraindications, no complications involved with it. short of the occasional tears that are shed in the office. From pain. But it's great because this is a mechanism that initiates a regeneration of the soft tissue and the bone with improved blood supply. And what it's really great is that it can offer us the ability to allow healing for our patients, our athletes that want to continue training at the same time. And this is really paramount for most of our athletes and the success of our athletes. Okay, so what are the biological effects of the acoustic waves in the musculoskeletal tissue? Well, acoustic pressure waves create what are known as cavitation bubbles, and they therefore create capillary microruptures, which lead to the expression of different growth factors. And we can talk all about those growth factors, what they stand for: the bone morphological protein, proliferating cell nuclear antigen, the vessel endothelial growth factor, and the endothelial nitric oxide synthase are primarily ones that have been studied, and they've been proven to improve neovascularization, improve blood supply, and therefore causing bone repair, tendon repair, soft tissue repair, and ultimately tissue regeneration. Other things that we know to be true is we see a reversal of chronic inflammation, mostly through mast cell activation. We see collagen production, mostly through pro-collagen synthesis, and we also can actually see dissolution of calcified fibroblasts. So it really is quite a technology, and it really allows for regeneration and repair, and to get our athletes back on the track as soon as possible. So how does it work? Well, we know that it's a pneumatically driven device whereby compressed air is used to send a projectile to a transmitter or the applicator. And therefore, this transfers a shock wave to the skin and from there into the body, causing all these different biological effects. And there are a multitude of scientific documentation to validate and demonstrate the clinical effectiveness. There's many different studies. These are older studies, but what it shows is that it's proven to have an 85% effectiveness rate for plantar fasciitis and Achilles tendonitis. And in our practice, we like to say that it actually has closer to a 94% success rate. And I think this is largely because we are seeing so many athletes, high-end athletes, and they're all fairly healthy. So we might have a skewed population in that sense. And this one study here demonstrated that with plantar fasciitis, in studying 25 patients, the visual analyzed score went from a 9.2 to 1.8 by week 12, showing a 90% improvement. And this is great. It gives us a nice guideline to say, okay, at the 3-month mark, we want, we know whether or not EPAT was effective. And generally, we see patients at the 6-week mark. And if you're not at least 50% better at that point, then to figure out, well, we need to either add a different treatment, whether that be stem cells, potentially consider surgery, just kind of switch gears a little bit, because we'd like to achieve that 50% effectiveness rate at that 6-week mark. So it's just a nice guideline to say, okay, in three months, this is going to work or not.
Mm-hmm. Good point.
I'll let Dr. Connors.
All right, if I could just go, I'm not going to go back to the slide, but I've been doing Shockwave for about at least 15 years. And I started out, the only option we had was the high energy, and we would have to call a company. They would come in and, we would anesthetize the patient locally, and we'd do the high energy treatment on the patient. And then we'd immobilize them with a ankle brace and a cam walker. We'd pretty much shut them down for anywhere from 2 to 4 weeks. And also with the high energy machine, we're very limited on the anatomical areas that we were able to do. Primarily, we're only able to do plantar fasciitis and Achilles tendonitis, which happens to probably be the 2 most common conditions we see in our practice every day. But then Rob introduced himself to me, and we started experimenting with the lower energy. And there's studies out there showing that the lower energies, doing it 3 to 5 treatments, we've had a greater success with the breakdown reparative process of doing the shock wave, waiting a couple of days, doing it again, wait a couple of days, hitting them again, that breakdown reparative process over 5 or 7 treatments has really upped our success rate. So, I encourage people, if you have a sports medicine practice, to look into getting one of these machines, because now we're able to do more anatomical areas because of this handheld piece right here, which makes it easier for us to do the shin splints, the patellar tendon, the iliotibial band, things like that. But there's different heads that we use on this machine. Some are more focused, some are wider, some go deeper, some are penetrating deeper. There's different heads that we use depending on the anatomical area and the depth that we want to go down to. Now, also connected to the machine is a V-actor. It's a high frequency vibration applicator. This comes with the machine, and this is the equivalent to what's out there now, the Theragun, the Hypervolt, different things like that. And we like to use this. This is more of a deep massager, a deep vibration. Its uses, it reduces muscular strains, eliminates trigger points, increases blood flow to the area, and stimulates muscle toning. So we like to do this on the affected anatomical area prior to beginning the EPAT treatments. As I mentioned, over the years, Katie and I have had the opportunity and the honor to treat, travel, and train with some of the best athletes in the world. And it's really an honor to be able to work on these athletes and see them perform at their great level that they're capable of doing, knowing that when they came into our office, they were injured and we got them back. And oftentimes, again, our first line of treatment is the EPAT treatment. And we've not had to do so many surgeries because of this EPAT therapy that we have in our offices. Now, if you can take anything home from this lecture today, this is it right here. The key to successful treatment is to treat the cause of the injury and not the symptoms. The EPAT treats the symptoms, but when a patient comes in to see Katie and I, we do a complete analysis on them. We do a quick biomechanical examination to see, okay, where's the problem coming from? What's causing the plantar fasciitis? What's causing the Achilles tendonitis, the posterior tib dysfunction?
I'm not talking.
You?
Somebody's talking.
It's not me. It sounds like the recording from before.
Right. So anyway, you have to look and see what's causing the symptoms. Very important. Also, in our sports medicine practices, we like to surround ourselves with different doctors of different specialties. This is a good friend of ours, Dr. Sharma. He's a pain specialist doctor. We surround ourselves and interact with different orthopedic surgeons, endocrinologists, internists, chiropractors, physical therapists, athletic trainers, and non-operative primary care sports medicine specialists too. And we communicate all the time, sending patients and, what do you think? What should we do? This is what we propose to do. So we have an open line of communication with all these different doctors of different specialties, which is very, very, very important. Okay, so here is the tip guide that Rob threw in here. The different tips right here, like this one right here, the 20 millimeter, this is more surface area. And then as you get down to the 15 millimeters, you got the titanium head, and you got the, what's the other one, Katie?
The ceramic head, so the C15.
The ceramic head. So really the only 3 heads we use are the
C15 and the D20s.
Exactly, the 15 and the 20, and that's plenty in the field of podiatry. Plantar fasciitis is probably the most common condition we see in both our practices. I'm sure everybody out there too has a sports medicine practice. Plantar fasciitis. What causes plantar fasciitis? You name it, it causes it. High arches, flat feet, overtraining, inadequate, improper training shoes, inflexibility, hyperflexibility. There's no one root of cause for this right here. And this works, the EPAT works very well with plantar fasciitis here. And just to go through our protocol, I know historically speaking, the protocol is 3 treatments, 7 days apart, at 3,000 hits of the 15 millimeter head. Katie and I like to do 5 treatments within a 2-week period, and then we wait 2 weeks and have them come back, and then we evaluate them. And we use ultrasounds a lot too, and we take measurements before the treatment. We take a measurement after the 2-week period, and then we do it at a 1-month follow-up too. And we can see the healthiness, the integrity of the plantar fascia. If it's decreased in thickness, and but that's our protocol. We do, instead of doing the 3 treatments, we do 5 treatments, typically 3 to 5 days apart. Do the 5 treatments, wait 2 weeks, they come back, do another ultrasound, and then a month later they come back. And after, we have benchmarks and guidelines. When they come back after that 1-month period, we want them to be as close to 90% better, like Katie was saying before. And if they are fine, if they're not, then we have to go into, okay, maybe we have to do a different type of treatment modality here. But typically for the shockwave, for the plantar fasciitis, we like to take that Theragun, if you will, the V-actor, and run it along the course of the plantar fascia just to loosen it up. And then we'll take the 15 millimeter head and we'll hit them with 2,000 hits. We'll do the 15 deep, 2,000 hits, and then we'll take the 20 millimeter head and give them 1,500 shocks throughout the plantar fascia here. But I got to tell you, every time a patient comes in, this is not in stone right here. Everybody's different as far as what we're using. We're using the deep head, we're using the 15 millimeter the whole time, or the 20 millimeter the whole time. So, for those of you that do this out there, you'll develop your own criteria, what works best for you. Mm-hmm. The Achilles tendonitis right here, very, very common. There's 2 different types. There's the insertional and the mid-tendon. Mid-tendon is very, very common. They come in, they have that bulbous inflamed area at the distal 1/3 of the Achilles tendon right there. And this is, I'm performing shockwave on someone's Achilles tendon right here. And again, the protocol is the 5 treatments, wait 2 weeks, and then come back 1 month later. We do the ultrasounds before the treatments at the 2-week mark and at the 1 month mark right there. We use the V-actor just to loosen up the gastrocsoleus muscle complex right there. Then we'll take the 20 millimeter head and hit it right on the tendon. And then I like to, and Katie likes to, hit them with the 15 millimeter at 3 different angles. So you can see right here, I'm hitting it directly onto the Achilles tendon, and then we go medial and laterally. So we're getting all 3 angles right there, which has proven to be very, very beneficial. In addition to doing the shockwave, and same thing with the plantar fasciitis, we get them into the night splints. We like to the patient to get the TENS machine so they can stim the affected area every night. And with the Achilles tendon here, it's very important when you're doing the shockwave, or when you're treating Achilles tendon, is to get them started on a home exercise program, particularly eccentric exercises to strengthen up the Achilles tendon. You don't only want to stretch it, you want to strengthen it too. And then the shin splints, this is the most common condition that we see in the high school athlete, particularly the female athlete. They're going from elementary school and they're running 10, 15 miles a week. And then they go up to high school level and they're running 50, 60, 70 miles a week. So eventually the body breaks down and they come in and they got the classic posterior shin splints. There's 2 types of shin splints. You got the posterior shin splints and the anterior shin splints. I would say 90 to 95% of the shin splints we see are the posterior shin splints, the posterior tibialis muscle. Again, you got to look at and evaluate the patient, say, what is causing the shin splints? Is it overuse? Is it mechanical? Is it a weak core? Is it a flat foot, which is straining the posterior tib? You got to treat the underlying cause and then treat them with the shockwave therapy. And as you all know, you got to treat the shin splints because the shin splints, the medial tibial stress syndrome, is a precursor to the stress fracture, tibial stress fracture. So with the shin splints, we allow the patient to run with some modifications, getting off the road, getting off the hard surface, getting on a softer surface, which is more forgiving on the body. go through the proper sneakers, make them the orthotics if possible, get them on a core strengthening program. But with the shin splints, we allow them to train through this while we're doing the treatments. And
with that being said, I just want to mention that, you know, we do worry about stress injuries, stress fractures with shin splints. And, you know, there was a nice study that was done by Amal Saxena, and, you know, he basically had this protocol of giving Shockwave every other day to two athletes, one of them being the Olympic, you know, winner, gold medalist in the mile. And, you know, they did that protocol, and he actually stayed running. It was underwater treadmill running, or was Ultra G treadmill running, but he stayed active while doing these treatments every other day. And he was running on ground at 4 weeks. He won the Olympic trials at, I think, week 7 or 8. And then 17 weeks later, he was, you know, the gold medalist. So just keep in mind that we don't necessarily have to, you know, shut people down for the extended 6 to 8 week period. We can maybe shorten that up. And I know there's only case studies looking at that right now, you know, in terms of stress fractures, but it's really interesting to kind of play around with that and see if maybe even imaging studies can help, you know, in the future of getting these patients back a little bit sooner.
Yeah, that's a good point, because even if the patients do have a stress fracture, we're still treating them with the Shockwave. It's just that we have to shut them down temporarily running. But with the you know, invention of the Ultra G treadmill, the underwater treadmills, the patients are able to cross train while they're nursing their injury, and we're treating them, getting them back to you know, health. Okay, same thing here. We do the V actor. Let's do loosen up the posterior muscle belly. We go 1,500 hits with the 20 millimeter more into the muscle belly, and then we take the 15 millimeter and go right off the crest of the tibia right here, right around the periosteum right there. A little painful, but it works very well. Patellar tendonitis, very, very common. Again, what's the cause of the patellar tendonitis? Typically, it's weak core, limited external hip rotation, weak vastus medialis muscle, and overpronation, which is causing an abnormal pull of the conjoint patellar tendon, and it's causing inflammation right in the patellar tendon right here, or at its insertion point right here. So once you treat the cause and you get them on a home exercise program or get them into physical therapy, we start the treatments. Again, we do the 5 treatments for the patellar tendon. We do the 20 millimeter right into the tendon right here, and then we do the 15 millimeter at 3,000 hits, oftentimes 4,500 hits, and we'll get them the same way we got the Achilles tendon. We'll go directly on, and we'll go medially and laterally. And then we've had success with torn meniscuses too, myself included. I had a tear the posterior horn medial meniscus, and I couldn't run across the street. I didn't have surgery, didn't go to physical therapy. Rob the Waters came into my office and hit my medial knee joint like 7 times. And it took a while. It took 8 to 12 weeks, but I did get back to running, and I can run 7 days a week. I run 4 to 5 times a week, but it has been worked very well and beneficial on the meniscal injuries too, and chondromalacia too. And also we like to work on the hamstrings, because tight hamstrings can cause patellar tendonitis. So you can't lose sight of that. We always check their hamstring length. Iliotibial band, very, very common. Typically they get the inflammation at the, right where the iliotibial band comes over the lateral femoral condyle right there. You can see how it turns right down where it's circled in blue right there. They get that inflammation and inflamed bursa sac. I must say that there's a direct correlation between iliotibial band syndrome and weakness of the gluteus medius muscle. So we evaluate that too. We watch the patient walk, we watch them run, we look for that Trendelenburg gait. Lots of times we have the runners take a video, or somebody take a video of them on their cell phone, and we analyze their gait running on the track or in the woods. And oftentimes people with iliotibial band have a weak gluteus medius muscle. So how do we treat that? The same way we treat everything else. We do the 5 to 7 treatments. We do the V actor all along the tensor fascia lata and along the iliotibial band with the 20 millimeter. But then when you get right down into the lateral femoral condyle where the inflamed bursa is, that's when we'll hit them with the 15 millimeter, more focused EPAT tip at least 3,000 to 4,500 times. And again, you got to treat the cause, and oftentimes it's the weakness of the gluteus medius. Yeah, I lost my slide for a second. This is very, very, very common. We see this all the time in particularly high school and collegiate female athletes. Tight hip flexors, the iliacus and the psoas muscle, very, very common in high school girls. Oftentimes, and we're seeing a lot of apophysitis, whether it's a hip apophysitis, Osgood-Schlatter's and Sever's disease, which the Shockwave works very, very well. We do Shockwave on Sever's, Osgood-Schlatter's, and oftentimes the open epiphysis right here where the iliacus attaches to the crest of the hip right there. You get them into physical therapy, you get them on a core strengthening program. But again, we do the 5 to 7 treatments. We do the V-actor to loosen up the hip flexor muscles, get them on a strengthening program. We'll hit them again with the 20 millimeter per 1,500 hits, and then we'll go at it deeper with the copperhead with the 15 millimeter head at least 3,000 to 4,500 times. And again, they come in for 5 to 7 treatments. And the Shockwave has proven to be very beneficial on these growth plate injuries. Katie, do you want to say anything about, because you see a lot of the girls with these hip apophysitis?
I do, and I've dealt with the iliopsoas bursitis myself too. So hip problems are really, really common. Like you said, in that female athlete, the high school and college athlete, and it'll look like a stress fracture when in fact it's actually just hip apophysitis or the bursitis. So yeah, I mean, I've dealt with this myself, and I've actually been recommending something called the So-Right to a lot of my patients. I've gotten you one too. It was pink. But I found that personally speaking, that it's made a huge difference in being able to stay injury free. I find that limitation in hip abduction and external rotation really causes a majority of the lower extremity injuries that I see. So no matter what, if I'm dealing with shin splints, plantar fasciitis, I tell the patient, get the So-Right. Yeah. I think it's so important to, like I said, staying injury free.
Yeah, that Katie bought that from me. It's a game changer. I use it on my my hip flexors, my insertion of the hamstrings, and my SI joint, and has really made a difference in my running. Another school of thought where we're talking about the hip injuries here. Whenever a female, whether high school, collegiate, or midlife runner, female runner, comes into our office complaining of vague hip pain, or it's Katie, our rule of thought is that we always send them for an MRI, because this is an area that you don't want to mistreat or misdiagnose. And we always send a patient when they have vague hip pain for an MRI to rule out a femoral neck stress fracture. That's the first one we want to get off the table, is a femoral neck stress fracture. So the school of thought, if they come into your office and they complain of vague hip pain, send them for the MRI just so you get the right diagnosis and you can treat it the right way, because the worst thing you could do is treat someone for a hip flexor strain where indeed they had a femoral neck stress fracture. So school of thought, we use MRIs a lot, just to, the patient said to us, how long am I out for? We're pretty much, Katie and I know with our experience with this injury, you're going to be out for this long, cross-training on the Ultra G or underwater treadmill. But to give them more definitive ballpark and when they can get back, we send the patients for the MRI, especially, with the shin splints. Is it pure shin splints, or is it a stress reaction or a stress fracture? So it gives us a better idea of the prognosis of the injury and how soon they get back to training and doing what they enjoy doing. The effects of the Shockwave, the nice thing is it's performed in the office. As I mentioned to you, Katie and I have 2 practices. We have a practice in New Jersey, in the practice in New York City. We have 2 Shockwave machines like this right here that you're looking at in our New Jersey office, and we have one in the New York office, and we're using the machines all day long. The beauty of this is no anesthesia required. The patients can come in, they get the treatment, and they leave, and they can go perform their exercise. They can run. You do not need a sterile environment. It's fast, safe, effective, and the consistent effective results are reported in the literature. And Katie and I can vouch for this, that we wouldn't be doing it. We wouldn't be wasting the patient's time, their money, if we didn't think it works. This is a game changer. This machine right here is as far as our treatment plan, getting the patients in, getting them better, getting them back doing what they want to do. And we have a protocol. We have a plan when all the patients come in. And this is a very important part of our plan when we're treating the patients. And Katie and I believe in this machine. It works. It's proven to be beneficial, and it's not even a sell. If you believe in something and the patients see that you believe in this and it works, they're going to do it. They're not going to ask you, well, why? And it works. And we have proven success on both the weekend walker, jogger, runner to the Olympic athletes. They can attest to the effectiveness of this machine right there. It's proven to be very beneficial over the years. And the nice thing too is that with the head right here, we could do multiple body parts, whereas when we were doing the high energy one, we were very, very limited on what we could and couldn't do. We can pretty much only do plantar fasciitis and Achilles tendonitis. This has enabled us to do many more anatomical parts. The patient selection, as Katie mentioned before, we do it on the acute tendinopathies, the chronic tendinopathies. We do it on all of our post-operative patients. Every patient that has surgery, scar tissue is a normal part of healing, but after a period of time, we get them into physical therapy, and they come into our office once a week, 4 or 5 post-operative shockwave treatments, just to accelerate the healing process and to break down the scar tissue, which is the normal part of healing. It's a nice adjunct to platelet-rich plasma therapy. Years ago, I primarily did platelet-rich plasma, but now Katie and I primarily do more the stem cells or the stem cell activators, the different ones that are out there. We do a lot of that. But what we do, even if our plan is to do the PRP or the stem cells or the stem cell activators, we always do the EPAT treatment first, even if we're going to do the PRP or the stem cells. Why? Because they have a lot of damaged tissue, and we like to break up all that tissue and get good blood to the area, get the viability back in the tendon, whatever tendon we're working on. And then once we create a healthier environment from doing the EPAT on the patients, then we introduce the PRP or the stem cells or the stem cell activators, which has proven to be very, very beneficial, because we like to create a healthier environment when we inject the stem cell or the stem cell activators, because these are undifferentiated growth factors. So we want to put it into more of a healthier tissue environment. And once these stem cells or stem cell activators realize, okay, I'm in a ligament, I have to mature into ligament. I'm in a tendon type of tissue, I have to mature into tendon type of tissue. So again, even if we're doing, our plan is to do the stem cells or the PRP, but primarily the stem cells or the stem cell activators we're doing now, because we could do that right in the office. We do the series of, not the 7 treatments, we do 5 treatments in a 2-week period. And after the 5th treatment, when the patient comes to our office, after the 5th treatment, we prep the area, and then under ultrasound guidance, we'll inject the whatever product, the amniox or Iris got a nice product that we're going to look into, the stem cell activators. So both these products, the stem cells and the EPAT, are a major front line as far as our treatment, the way we present our treatment plan to the patients right there. And then the use of the V-Actor, we have this hooked up to our machine, but there's so many products out there right now. Again, the Theragun or the Theragun-like modalities that you can buy online, or you can buy in any running Dick's or any running specialty store, which I encourage patients to do too, because after a hard workout, or not even a hard workout, you do the Theragun or the Theragun-like machine, and it just gets the lactic acid out of the muscles, and it speeds up the healing by getting blood to the area. Want to mention anything here, Kitty?
I think you got it. Yeah. Good. Actually, interestingly, we don't do a lot of PRP, but I do know that people actually do shockwave to the test tube of the platelet-rich plasma to release those growth factors. So just keep that in mind. You can do that as well.
All right. So the treatment protocol, basically you hit where it hurts. That's Katie, our motto right there. I mean, you got to know what you're doing, but hit it where it hurts. Prior to the treatment, the physician, we localize the area. Again, we use ultrasound. We have ultrasounds in our offices, and we use it all day long. And the patients like to see that because they can see the area of inflammation. We measure that. Even when we're doing the stem cell injections, we do everything under ultrasound guidance. And of course, you want to use a coupling gel when you're doing the shockwave. You position the target area against the treatment applicator. And again, here's the protocol right here, 3,000 pulses at 3 bar, energies measured in bar or as tolerated. Again, Katie and I, our protocol is to do the 5 treatments within a 2-week period, wait 2 weeks, they come back in, we do another ultrasound, we hit them with the shockwave, they come back 1 month later, do a follow-up ultrasound, and we hit them again, and we measure their, how they're doing at that 1 month mark right there. And if they're doing fine. But if they're spinning their wheels in the mud, then we have to go to plan B. We always have plan B. Again, if there are different heads, but primarily in the area of podiatry, you only need to use those 3 heads that we mentioned and the 3 to 5 treatments. We went through our protocol that we do, Katie and I do, when we do shockwave therapy. And we, when patients come to see us, we charge the patient for the package. So we force them, but if they pay for the package, then they're, hello, Katie.
Yeah.
Where am I? I'm
You're lost.
I'm lost.
Can I help you, John?
Oh, there. Hang on.
Did you lose? Did we
back? Yeah. Okay. So, from a practice management standpoint, when patients come in, we line up the protocol. We tell them about the treatments, a 2-week, the 1 month follow up, the ultrasound, and they pay up front. By paying up front, it's going to force them to be patient compliant, and they're going to come in for all their visits. So by doing that, our success rate is very high, because if they pay each time they come in, then they're going to fall off the cliff, and then they might come in for 2 treatments, 3 or 4 treatments. So school of thought, we charge everybody up front for the quote unquote package. The package involves all the treatments and the ultrasounds too. Okay, after treatment, patients can ambulate and weight bear immediately. Unlike in the past when I was doing the high energy one, which is still a great modality, the high energy. For those of you that aren't using this machine right here and you have no other choice, use the high energy one. For years I used the Northern Lithotrips, a bunch of good guys. They're very accommodating, and they were it worked too, but you got to shut the patient down. You have to locally anesthetize them. With this low energy one, with Rob's machine here, it's been very beneficial for us, because the athletes can continue exercising. We don't have to shut them down. With reductions though, you don't want to ice the area, because what we want to do is get blood flow to the area. I like to use the analogy of the shockwave, like the guys outside with the jackhammer that are breaking up the road or the sidewalk. It's basically the same thing. We're sending the acoustic waves into the affected area, and it's breaking up all the scar tissue, adhesions, fibrosis that has formed in the area, breaks it down, and your body senses an injury, and it sends platelets, growth factors down to the injured area, and there's a whole healing process. But the shockwave is the same as the jackhammer guys outside breaking up the sidewalk and the roads. No anti-inflammatory medication, because we want we are creating an inflammatory response. Can take Tylenol, but typically when people after the first treatment, they walk out of here starting to feel well right away, because we're breaking down the scar tissue or the adhesions, what have you, and we're getting blood to the area. So even after the first treatment, When they get off the table and walk out, they say, "Oh my God, I'm starting to feel better already." But they got to keep coming back to complete the protocol for it to work effectively. And they can take Tylenol, but pretty much you don't have to. Success, keys to Shockwave, keys to success, proper patient selection, as Katie mentioned. We have a nice draw. We have healthy patients who want to get better. Exercising is a very important part of their life. So we have a great patient selection, and that's why our success rate is so high. As Katie mentioned, you have to set right expectations. They're not going to get better after the first or second treatment. You saw that vast study that could take up to 12 weeks to get better. So you have to be upfront with the patient. So you have to be patient with this treatment. It's going to work, 94% success rate, but you must be patient. And again, they must complete the entire treatment. That's why we charge them up front for the whole package, and they keep coming back. Give the patients time to heal, 6 to 12 weeks. And again, we do the follow-up ultrasounds, and oftentimes we'll do an MRI. But school of thought, don't send them for an MRI 2 to 3 or 4 weeks after or while you're doing the MRI, but it's going to come back as increased blood flow area to the affected area, and it could look worse. But this is actually what you want. You want increased blood flow to the area. So we stop sending patients for MRIs too soon. We'll wait the 12 weeks to send them for the MRI if we need to. But that's why we have the ultrasound in the office. We can do a diagnostic ultrasound right there in the office. Katie, anything?
That's all. Yeah, no, that's good.
The reimbursements, typically it's not a covered service. The insurance companies feel that this is it's considered experimental, and it's not. It works, and numerous literature out there has shown that it's very effective. But the insurance companies don't want to cover it. But again, if you believe in a product like Katie and I believe in this product, their patients are going to see our sincerity and how much we believe in this and how much it works and who we do it on. They're going to buy into this because they're going to get better. And you're not operating on them, and you really don't have to shut them down. It works. And again, it's a major part of our practices. This machine right there is really the cutting edge for us right here. Treatment options, again, you got the EPAT, the PRP, and the stem cells. And then oftentimes, say for insertional Achilles bursitis, if the Shockwave doesn't work, we have our protocols. We do this minimally invasive procedure, the FAST procedure by 10-jet or 10x, but we always do the EPAT procedures first. We have a 94% success rate. Those 6 to 10% of the patients that don't get better, we do this minimally invasive procedure. It takes about 2 minutes to do. Again, 10x or 10-jet. For those that don't get better, we do that, and that has proven to be very, very beneficial too. And again, we do, if we're ever doing the PRP or the stem cells or the stem cell activators, we always do the Shockwave first, the procedures first, the 5 treatments first, for the reasons I mentioned before. Okay. So, it's the clinical applications of what we do in our practice is every day. And, we'll field some questions now. I think we got a couple minutes for questions if anybody has any questions.
Yep, we got a bunch, which is great. Excellent. Thank you, guys. We'll see what we can squeeze in here in 10 minutes. Iggy, you want to get him started?
Yeah.
That's his other real nickname, by the way, besides Rolodex. It's Iggy. So there you
go. So I will tell you, John, just a quick story. I will tell you that, are you familiar with an orthopedic surgeon by the name of Richard Alvarez? So he did the original studies with the original Shockwave machine. So actually, the first Shockwave machine that was brought into the Oscitron, when it came out, I was actually an investor in the initial machine because he was one of the founding physicians based out of Chattanooga. So I very much appreciate what you're saying with the high energy machine, because I had originally was using the Oscitron and that thing hurt like heck, and this is so significantly better. So we had a lot of questions, and I think some of them are repetitive, but some of them are not. And so the first one I have is the acoustic pressure wave the same as Shockwave?
Yes. It is. Well, there's different, I mean, acoustic pressure waves, you have the radial pressure waves, and then you have the more focused shock waves. But this, we're mostly talking about the radial shock wave therapy.
Excellent. So one of the things I think you guys already covered, a question was about insurance coverage of coding. And so we can even speak to that, and you can as well, but it's not covered by insurance. I think the term, John, you used well, with the insurers love to hide behind is experimental and investigational.
Yes.
Even though it's been around for a long time, the bottom line is that means we don't want to pay for it.
Right.
So, yeah, despite the literature and the successes that you guys have proven every day.
When the patients pay, we send the bill electronically to the insurance companies. We tell the patients we will do a courtesy. We'll send it to the insurance company, and every now and then one or two will pay, but for the most part they don't pay. It's experimental, and the patients know that up front.
John, as a dovetail on that, I noticed you indicated that you do sell a package. I know that the ultrasound is actually a covered service. Is it because of the frequency of how many you might do during a patient's treatment protocol that you put this in a bundled price instead of billing for the ultrasound? I'm only asking because we've seen a few billing questions, and I wanted to just ask you about that.
Yeah, good question, Ira. We will charge the patient or the insurance company for the initial ultrasound, because I think that it could be wrong, but I think the insurance company will allow you they'll pay for one ultrasound. So we charge them for the first one, but the next two are covered in that package that they pay.
But that makes sense, and that's why I was asking. I will tell you that there's been quite a few questions, and if you don't answer them all, everybody, I will reach out to Dr. Connors and Katie, and we'll get answers and send them to you. But people have asked. There's been a few questions regarding your protocols, John. Are those something that you would make available to any of our attendees? Do you and Katie have a written protocol, or would we contact Rob DeWaters? How would we get some clinical protocols or guidelines that you are using in the care of these patients?
Yeah, feel free. We can give that to you. They can reach out to us, but Rob knows our protocols too. He knows how many treatments, the intensity, the duration. But we can share that with. I had it on a couple of slides right here, our protocol. But like I said, it depends. It's not written in stone. Our protocol. It is, but then every now and then we change it.
Right.
Are we working on an Olympic athlete? Are we working on the weekend warrior? We're going to hit the Olympic athlete harder. We might hit them every day. We might hit them twice a day because they're only in town for a week. So we want to get all the treatments in. But pretty much the standard protocol is what I talked about here. I can share that. I mean, you're going to keep this up, right?
Yeah. Oh yeah. I guess you just brought up something that made me think of something. Not a question here, but you mentioned that you might do an Olympic athlete twice a day. Do you find that more treatments in a shorter period of time is more effective? Would you look at just a weekend warrior who's got a very bad recalcitrant plantar fasciitis? Would you do them twice? I mean, how do you determine, you know what I'm saying, and what's the increased efficacy by the multiple applications?
Well, the protocol per the company is 3 hits 7 days apart. So you hit them every 7 days.
Right.
But Katie and I like to hit them the 5 treatments every 3 days. So we shorten the time. We hit them more often, more energy. And we found that again, that breakdown reparative process process has been more beneficial than doing the 7 days apart. Now, why do we hit some of these athletes twice a day? Well, if the Kenyans are passing through town, going from New York, running a marathon, and they're going up to another race, or they're leaving the country in 5 days, we only have 5 to 7 days to hit these people. So we want to take as much advantage of the time that we have with them. So oftentimes we hit them twice a day. But for the general lay public, we don't do that.
Okay.
So I saw your one of the questions was, we saw your protocol about Achilles tendonitis. How about the insertional version? Is it any different than that standard fusiform swelling type?
Good point. Thanks for bringing that up because that wasn't in the slides right there. But the protocol is the same thing. When I hit the insertion, the same angles that we do the mid tendon, we hit it from medial and lateral and straight on. So we do the three different angles right there. Thanks for bringing that up.
Here's
and again, you get them into physical therapy and you get them into the eccentric strengthening exercises. But mid tendon, when you do the eccentric, you put the foot half on the stair, half off, and you drop the foot past the stair. When you do the eccentrics for the insertional, you only do it to the floor. You don't go past the floor because it can further irritate the insertional area. Am I correct, Katie?
Yes.
Rob, I'm curious, and Katie, what Rob? I'm thinking Rob the Waters. When you're treating these patients, and I know many of them may have biomechanical abnormalities, and I know you said that you do an evaluation. At what point do you look at possibly orthotics or any type of biomechanical adjustments on the patient, or do you just treat the condition first? What do you do? How does that fit into your protocol?
Day one is, you have to start with that, or else it's like you're spinning your wheels if you're going to start the treatment. So
yeah,
often we wait until they have their orthotics before we even start the treatments.
Yeah.
So.
Yeah. So is that part of a mandatory protocol? Like I know you said, like I know that before I used to do heel spur surgery, I wanted everybody to try orthotics. If they, or endoscopic plantar fasciotomy, people who didn't respond, if I was going to treat them surgically, they always orthotics had to be part of their protocol. So I was just curious as to.
Yeah. Again, one slide. If you get anything from this lecture, it's you got to treat the cause. You don't chase after the symptoms. So like Katie said, and you said, Ira, if they have a biomechanical issue, you got to treat that first. When a builder builds a house, what's the most important part of the house? The foundation. You got to treat the foundation first, or you're wasting their time and money on the shockwave. So oftentimes we'll treat the abnormal biomechanics, whether you get them in an orthotic or get them going in physical therapy, and then we'll hit them with the shockwave. Once we stabilize them, then you treat the symptoms. That's why it's important to look at the whole athlete. They're complaining of plantar fasciitis or posterior tib or Achilles tendonitis. You have to look at the whole chain. They have a weak core, limited external hip rotation, weak VMO, tight iliotibial bend. You have to look at everything. You got to watch them walk. You got to watch them stand. And if possible, you watch them perform their sport by someone taking a quick video of them doing their sporting activity. And Katie and I can assess what they're doing right and what they're doing wrong. And oftentimes, if we're working with runners, we bring in coaches to work on their forms. So we have a whole team of people, not just doctors, but nutritionists, biofeedback specialists, running coaches. We surround ourselves with a whole group of experts in their particular field so we can reach out to each other and all come together working on the patient.
So one thing that question that came up, and I noticed it on the chart, is there were different 15 millimeter and 20 millimeter tips. Which ones do you use? Does it depend on the condition? Ceramic versus titanium, etc.
The ceramic tip, I'd say we use probably most often. We'll switch over to the other smaller titanium.
No.
When we're getting into deeper tissue. So even bones, we'll hit, if we have to hit, get deep into, the femur or something like that, we'll do that, or the glute maximus medius, things like that.
Yeah. The titanium goes deeper.
I noticed that you guys, and usually Mike and I try to end on time, but we've had a few extra questions. So I am going to ask you, I know that you mentioned about the possibility of PRP or, amniotic injections, but somebody actually asked a pretty good question, at least I'm curious, is can you use this in conjunction with like cold laser therapy? Are you using that as well, or is it contraindicated or not recommended when you're doing the EPAT therapy?
I don't understand the question. Do you, Katie?
People use cold laser for pain. They use the lasers for, again, as a non-covered service that they're using for pain control. Can you use this in conjunction with doing the EPAT, or should they be kept separate? Is it a modality that could be used in conjunction or not?
we don't use that because we have such nice success with the, people come into our office talking, hey, this will be a good addition to your practice. And I'm like, why rock the boat? We have our protocols are working so well right now with the Shockwave, the amnioc for your product, the stem cell activators. We have such great success with that. So I really can't answer that because we don't use that.
People do ask, a common question though too is, okay, do you recommend acupuncture, all these things? And we say, sure, it can only complement what we're doing. It's going to increase, stem cell activation, get blood to the area. And these are all things that we're trying to accomplish with Shockwave.
Okay. Well, I will tell you that there are a lot of questions, I think, that are related to the cost. And I would tell you that we try usually not to talk about the cost of devices, but I will tell you that Medical Wave is a great partner. I'm gonna kind of wind it down for you guys because I think there were quite a few questions with regards to the cost and lease payments, and I'm gonna forward all those questions and those contacts on to Rob so that he can reach out to everybody. But I have to tell you guys that I really appreciate your time and coming on here, and I just wanted to forward. Rob DeWaters is the owner of Medical Wave. He is somebody that I've known for an extremely long time. He's been a great partner. Obviously, John and Katie have worked with him for quite some time. He didn't have to twist their arm to speak. It's something that they obviously believe in. Rob's information is here. He's been great to Taylor members. I will tell you that it gives you an opportunity to bring something into your practice that some of the leaders in sports medicine are doing. So I think that it's critical that you implement this. I know that Rob is probably going to reach out to everybody who signed up and follow up with everybody to let them know. And I just want to tell everybody about our next Taylor Tuesday that's coming up. This is actually another interesting device that's used in the wound care space. For those of you who treat wounds, the Ultra Mist is a non-contact debridement device that's used for wounds. I've seen amazing results. My practice was a lot of critical limb ischemia. But I am going to, again, thank John, who is an old friend. It's good to see him back and appreciate him coming on and getting to meet Katie for the first time. And I'm listening to both of these people talk about how much they do running. I'm already tired right now, and I'm going to have to take a nap. And of course, I get to do this webinar with Mike, and I can tell you that yes, we are doing this on behalf of Taylor Medical, but we're doing it really more importantly for the podiatric community. I think that, as I mentioned earlier, everybody in different ways likes to give back to the profession. Whether you're educating people on how to get better outcomes for your patients, whether you're providing people billing and coding tips, whether you're providing activity through your volunteering in your organizations. I think that we're a small profession and we are successful because of the fact that we are a family. And that's what we consider Taylor. Mike, do you have any other closing comments? Or John and Katie, do you have anything you'd like to say before we thank everybody for joining us on a Tuesday evening?
Thanks for having us, Mike and Ira.
Thanks to both of you, and it was a treat to have you here. And Katie, my son had a baseball career similar to your collegiate career. I wish some of these modalities had been around then to help him before they stuck a scope in his shoulder.
Yes.
Talking to a runner from Georgia Tech, every single school should have a Shockwave at their disposal.
Yeah.
Well, who knows? Maybe we can start reaching out to some of these teams. I know Rob does, but anyway, really, thank you all very much, and everybody, thank you for joining us today. We look forward to seeing you next week, and have a great evening. Thanks, guys.
Thank you.
Thank you.
Bye.
Bye.